Morning. I'm Dr. Ravindra Rannan-Eliya. I'm the Director of the Institute of Health Policy, which is an independent research institute in Sri Lanka. And I'm very glad to be here in Cape Town for the first time at the invitation of HASA. And I was asked by the organisers of the conference to come and share some of the global experience with achieving universal health coverage around the world. I should explain that in addition to my research in Sri Lanka, I coordinate a research network which looks at issues of health systems equity and health financing throughout the Asia-Pacific region, and I'm also a research director of the newly established Asia-Pacific Observatory on Health Systems and Policies, which is a mechanism which Asian researchers and policymakers are now using to learn lessons from the very diverse experience we have in our region. Now, my presentation yesterday, I tried to do several things. I tried to distill some of the experiences that countries have had in the past 250 years in achieving universal health coverage. And I started off by first saying what I thought universal health coverage is. Actually, in practice, we most of the time really don't have a good idea what we mean by that. There's actually not a great deal of global consensus. Different international agencies and different researchers and policymakers have quite different perceptions of what universal coverage means. So I started off by explaining what I think it means, and I think it basically involves really two different elements. I think it involves not just access to healthcare services, but the actual reality or observation that we see relatively equal use of healthcare services by different income levels in a population. So this is one important aspect, relatively equal or equitable use of healthcare services. The second aspect that I think of universal health coverage is also important is the idea that the health system should be able to protect people against the financial costs of obtaining medical care. And we use various terms for it, but the main idea is financial risk protection, protection against catastrophic or impoverishing health expenditures, and both these characteristics, I think, are core to the element of universal coverage. Now, if we look around the world, it's true that most developed countries have universal coverage, but an important thing to know, particularly for South Africa, is that there are low middle-income economies around the world who have also achieved universal health coverage in these two kind of dimensions. Now, in talking about relevant experiences for South Africa, one of the points I also made was that there's actually not much experience close to South Africa. There's no other country in the African region who can be fairly said to have achieved universal coverage. A lot has been said currently about Ghana, but Ghana's still on the way to getting there. It's not yet arrived. And most of the other examples in the developing world tend to be in middle-income or high-income Asia. Many of these high-income Asian countries achieved universal coverage, like Japan or Korea or Taiwan, when they were at roughly the same income level as South Africa. So I went through some of these experiences and I tried to identify what I think some of the key lessons from that experience were. One important point that I spent some time on was the finding or the observation that in practice there have only been two or possibly three different approaches to achieving universal health coverage. This is from all the experience in the world in the past 100 years or so. The first approach to universal coverage, I think it's familiar probably to many people in South Africa, is the British-style UK NHS National Health Service model, which is where you have tax-funded healthcare services, usually government delivery, reaching 80 to 90% of the population. And the private sector is essentially very small and supplementary. The second approach is social health insurance, which in many countries expanded to cover the whole population by using tax financing to provide subsidies for the poorer people or for people who are not in work and cannot make contributions. Both these experiences, I think, provide certainly workable models, but one of the observations I made looking at the South African context is that neither of these two models actually fit the South African context in terms of how you get there. Countries who achieved universal health insurance through a national health insurance model did so by covering the formal sector with social insurance, and then at some point they expanded that to cover the other segments of the population using taxation to pay for insurance premiums. In those countries, in general, when that was done, the poorer people, the people who were not initially covered, had access to no free care. They essentially used either low-quality public services, and they usually paid out of pocket to access those, or they paid out of pocket to access private services. South Africa is not in that context. South Africa has some insurance coverage at the upper end, but the bulk of its population currently receive largely free services from the Department of Health. They may not be the best quality, and there are clearly income-related inequalities, but it's not a situation where people are paying out of pocket. So the social health insurance model doesn't necessarily fit in terms of evolution to the South African context. Secondly, the British NHS-type model doesn't fit the South African context either, and the British and the example of other countries who have done this kind of approach doesn't fit the South African case. And the reason for that is that in those countries, the free healthcare services generally provided the hospital care for most of the population and the upper end of the income range, and the expansion to universal coverage essentially involved eliminating user charges to an existing delivery and improving access to an existing delivery network. That's not the case in South Africa because, in fact, the upper end of the income range in South Africa don't use any free services currently, and you don't have the delivery network in place to simply remove financial barriers and ensure access. So then I discussed what some of my kind of initial impressions from a few days examination of the South African context. I'm not an expert on South Africa, but I just offered my thoughts on what I thought the challenges were. The main challenges, I think, in South Africa are twofold. One is that you have a very large private sector. The private expenditure is around 4% of GDP, much higher than in many other countries, and you have relatively high prices in that private sector. I think the reason for that is because of the existence of insurance, and it will be necessary ultimately to reduce the spending gap between the private sector and the public sector if you're ever going to move towards universal coverage. And on that issue, I observed, certainly before I came, in the stuff that I read and also from talking to people here in the past 2 days, that the private sector, especially the insurance sector, has significant problems with cost control. And the global lesson on that is that it is essentially no country has been able to get private insurers or private financing agents to control the costs of medical provision through their own collective action. In order to get effective cost control in the private market, in the private insurance market, the insurers would need to ally themselves and be facilitated by some kind of state intervention. And I emphasize that's one of the key things which is missing in South Africa at the moment. The second problem in South Africa is that the public services are much worse, much less funded than the private services currently, and you would need to bring these up in order to integrate the systems. I think that's something that will take many years. It will need significant public investment in the short run, medium term. And the third thing which I've also realized recently is that you probably don't have enough healthcare workers currently to provide access to the whole population at an acceptable level of coverage. Certainly, it struck me, South Africa, I understand, produces 1,200 doctors a year. You have a population 3 times that of Sri Lanka, and we produce the same. I don't think you have enough doctors currently to ensure effective coverage for everyone, even if you could sort out the finance.